Government of India published this notification in 2020 September, where they launched district residency program, but it could not be implemented initially due to back-to-back COVID waves. It came into existence since April 2023 from batch 2021 onwards as a compulsory rotation posting of 3 months, including all the postgraduate medical specialities, that is in MD and MS specialities, in their 3rd, 4th and 5th semester, and it was done in hospitals which had a capacity of at least 100 beds. It was started with the principle that the essential tenets of postgraduate medical education are learning experiences and training in diverse settings, especially closer to the community, which are at the peripheral levels. The peripheral levels of healthcare include district hospitals, taluka hospitals, community health centers, which are closer to the population in majority of the country as compared to the medical colleges. And also, they are the basics of secondary level care provided in the country, with the aim of bridging the gap between medical education and the broader needs of the community. The primary objectives of launching DRP was to expose PG residents to the health system in rural areas, and with the main motto of learning with serving, and their involvement in national health programs, in their implementation, planning, monitoring and assessment of national health programs at district levels, and also involvement in various cadres under NHM, that is overall, it helps the residents to strengthen the healthcare at the district level. The benefits of DRP were that it helped them gain experiences as a multidisciplinary team and gain experiences in treating patients at the public health level, and improving their epidemiological skills, and also health promotion, and improve their leadership qualities and understanding healthcare and needs of the community at grassroots level, and improving their relationship with the community members. The strengths were that it satisfied the basic tenet of training, that is training in the diverse health conditions at the grassroots levels. The residents were able to address the resource scarcities at that levels, which helped them modify their methods of treatment, develop innovative skills in them, and to cope up with the real life situations which are faced at the rural level. They also were involved in the various national health programs and also improved their understanding towards it. A major benefit was increase in the PG resident seats, which the paramedical colleges could apply after 1 year of implementing of the DRP program. So approximately more than 4,000 or 5,000 PG resident seats could be increased due to this program, which was a boon to the students appearing at PG medical entrance examinations. This also decreased prescription by the quacks at the peripheral levels, which are very much common due to scarcity of doctors in those areas, and also promoted cultural exchange and diversity between the doctors and the community. And one more advantage was that the PG residents could opt for residency at near their hometown or their home state. For example, the northeastern residents could apply for DRP residency in their hometown itself under this scheme. It serves as an opportunity to improve the reading qualities of the resident because of the less hectic duties relatively as compared to the medical colleges, and less patient load, and improve their awareness of the patients at the community level. There is an ample of data available at the periphery for use in the research purposes, which can be utilized further. And it also involved their involvement in outreach activities like school health campaigns, mobile health teams. Overall, district residency program serves as a very good opportunity for the residents to modify health in a positive level, especially at the rural areas in our country, which include most of the majority of the population.
Thank you, Dr. Navneeta. So at the outset, it appears the district residency programs is sub question. The policy maker is happy. Yeah, this is the positive side. Let me speak the positive side. Then we'll come to Ram. who will be speaking the other side. And thank you all the postgraduates and residents who have come in. I need your inputs after they have completed about the reality. सब खुश हैं इसलिए कि पॉलिसी मेकर खुश है कि एक वर्कफोर्स मिल गई who can go and serve in the district centers, who can work whenever there are calamities, so they can be employed there. They are also happy that on paper you have them off work and you can have more postgraduates being enrolled. They are happy that yes, they are being trained in the community for the community so that they can serve the community better. That is the projection. Okay. Resident is happy. Resident क्यों खुश है? Resident is happy as she said. There is less workload. There is more time to read. Okay, you are away from the daily duties and consultant or ward round. ये सब छुट्टी हो गया 3 महीने के लिए. You are working in isolation and it may be near your home. So these are the advantages for the resident and maybe getting to know new people, getting to know new circumstances, getting used to the new environments. Resident is happy. The doctors or people who are working at those district places are happy. उनका काम कम हो गया, वो भी खुश है, तो सब खुश है. A win-win situation है, तो it's a difficult task for Ram to say कि भाई क्यों खुश नहीं है. So over to you, Ram, for the reality. In the sir will come for discussion after we have completed both sides of the coin. So we'll be happy to have you coming. Ram, over to you.
Good morning, respected dignitaries. Myself, Dr. Ram Vignesh, senior resident. Myself, Dr. Ram Vignesh, senior resident, Department of Pediatrics, GWALIOR, GWALIOR. I am here to discuss upon the reality of District Residency Program, that is DRP. District Residency Program represents a visionary reform aimed at strengthening the secondary level healthcare delivery and exposing postgraduate trainees to a diverse clinical environment. Although the intended objectives align with the national priorities in equitable health access and competency-based medical training, does the ground reality align with the original intention? Whether the motto, learning while serving, has been fulfilled? The answer to these two big questions is a big no. This is due to a substantial gap between policy aspiration and operational reality. Coming to the weakness of DRP, there is inadequate orientation of residents to their roles. Residents are posted to district hospitals, but with no clear instruction of what duties to be discharged. Such undirected jobs assigned to the postgraduates right have been due to a lack of orientation of district surgeons or administrators of district hospitals about the goals of DRP, and thus in turn leading to lowering the morale of postgraduates and failing to achieve the purpose of DRP. Residents are considered as just a mere replacement of medical officers at district hospitals instead of augmenting their work. There is insufficient equipment resources, manpower shortages. Many residents consider this as a leisure posting, which leads to adaptation of unethical practices for giving attendance and such. Coming to the challenges of postgraduate resident, there is an academic continuity gap. Academic rigor and specialty-specific learning often declines during DRP posting. There is an inadequate training time. Many postgraduate students feel that even 3 years of postgraduate medical education itself is not enough to learn even the basic skills that the NMC advocates in its true sense. In this regard, many would consider that DRP is bleeding out crucial time from their training time. And there is also reduced access to structured academic activities such as seminar, grand rounds, interdepartmental teachings, clinical audits, and journal clubs. Journal clubs has been an integral part of postgraduate teaching as they arouse the interest of the students in research, and this in turn fueled evidence-based medicine and promoted better learning through discussion and debates. Many residents feel that they have been missed out of these academic activities. And there is inadequate senior supervision. Excessive workload on faculty due to poor doctor-patient ratio in India leads to inconsistent mentoring, which may compromise competency-based outcomes. There is also a limited specialty exposure, especially in surgical branches, where complicated surgeries are being done only in tertiary care center, and in radiology, many PGs feel that they miss out their valuable time in learning new things related to CT, MRI, since they are only focused on doing ultrasonography in district hospitals. In pediatrics, due to lack of lab facilities and other resources, managing the patient becomes more difficult in district hospitals. Even being despite the available resources, they are made to refer the patient to tertiary care center due to lack of trained staffs or other reasons. Exposure to complex specialty cases is limited in district facilities. This affects skill development, particularly in surgical, anesthesia, pediatrics and critical care branches. In most district hospitals, academic learning from cases is generally passive or absent, with the completion of tasks prioritized. Systemic inertia often supplants the necessity for knowledge updates, while everyday experience of managing situations in demanding working environment suppresses professional interest. Evidence highlights the risk of skill dilution and delayed procedural mastery. Coming to infrastructure gaps, many district hospitals lack ideal infrastructure such as ICUs, advanced diagnostics, subspecialty backups, and adequate supplies. There is also shortage of drugs or equipment, deficiency in accommodation, sanitation, and support service further impact the training quality. There is also safety concerns, especially for female residents during their night shift who have to travel to and from their accommodation places in remote areas. And there is lack of proper doctor's duty room in many of the district hospitals, especially after a hectic night shift to rest, and not even a proper lavatory, which is one of the basic needs for a human being. Coming to administrative and welfare issues, administrative inconsistencies include unclear reporting such as stipend issues and absence of grievance mechanism. This variability across states and institutes affects uniform training standards. Coming to research and thesis challenges, this is one of the major concerns for a PG resident. There is data collection gets interrupted, ethical support is inadequate, and sample access becomes more difficult during DRP periods. This is particularly significant during crucial thesis data collection phases. And there is also poor internet support in remote areas where they are posted. Coming to medical legal and safety risk, residents report a sense of medical legal vulnerability in resource limited settings. Safety concerns include gender specific security issues and lack of administrative protection are well documented in many studies. These are some of the news articles and research articles regarding the issues faced by DRP residents. This is a study conducted in Rajasthan in India, where 46% of residents reported verbal or written abuse, 16% reported physical violence, and around 2 to 3% reported sexual misconduct or harassment from any member of the team. Coming to the mysteries of DRP, there are some unanswered questions. 3 months of postings for in-service candidate, whether it is necessary. For a post-diploma students, there is only a 2-year course of post-graduation course, out of which 3 months has been cut out. Primary DMB and diploma DMB students are left out from this learning, and there is no travel allowance. Moving forward, how can the program be improved? By improving orientation and training, standardized training modules, especially for DRP and DRP coordinators of the district and district surgeons. Comprehensive induction programs could be done, enhanced resource allocation and infrastructure could be made, strengthening the supervision and monitoring using regular check-ins, assessment, feedback sessions, integration of parent medical college, especially with consistent communication through online lectures or by discussion. Digital attendance should be made mandatory, and logistic challenges such as safe and comfortable accommodation, reliable transportation, support systems should be addressed. We should focus on ethical practice, such as ethical training, transparent reporting mechanism, promote research and data collection, community engagement and awareness, involvement in community campaigns such as WHO ORS Week, World Breastfeeding Week should be conducted at district level hospitals, gather community feedbacks. There should be a periodic review and stakeholder involvement, and adoption of standardized law book should be done for everyone.
Thank you, very good opportunity. So please come, you agree with Ram or Navneeta, or you have a different take altogether? Please, can somebody pass over the mic there? हाँ, ये बीच में भी माइक है, यहाँ पर आकर भी आप बोल सकते हो। वो डर है सर आपसे, आप गॉड सर यहाँ नहीं है। एकोमोडेशन के लिए मिलता है भाई, ट्रैवल के लिए नहीं मिलता। ओवरऑल अनाउंस है वही। ओके, ठीक है। दोस्तों, there is a provision for some allowance, there is some provision for some allowance, but he is not satisfied. Okay, please, better both of you meet. Okay, we'll come to the faculty. Thangavilu sir. Yeah, please take mic sir. Yeah.
MBBS, we joined DCH, so some of the 8 years gap was there. After DCH to MBA had 5 years gap. When I went to the district hospital, initially post district hospitals, what I realized was most important skill resident should learn is IVXS. Because most of the seniors, they won't do the IVXS. We were in the institution, we were depending only on the nurses. So that's what I realized. Then I realized that if they go earlier, work in a district residency program, they realize what are all the defects there which they should learn during the residence.
Okay.
Second one is I just screened about 5,000 children, had 41 anomalies. I took even a positive slides, prepared a presentation. when I come back to residency, I will know these are all the things I should learn. So that way it will be very useful for the PGs to go and work in a periphery.
So you think that the program is good, but maybe the implementation needs to be
from requested probably it has to be improved.
Yeah.
Yeah, that is a real life situation they are going to face after the MDR DCS.
Thank you, sir. Dr. Ajay.
Sir, I am not in favor of the DRP program, the present DRP program. That means I am with Ram. And there are so many reasons which Dr. Ram has narrated. See, the problem of first, I will see the problem of a HOD or a administrator. My four PGs are out for 3 months. And we have to rotate the clinical postings of the residents according to them. And they are out of the studies. Totally out of the studies. And what they are getting, a pediatric resident is posted in mortuary, a radiologist resident is posted in emergency setup. What they will do? It's a sheer wastage of.
अच्छा है ना सर, वो एक जनरल डॉक्टर तो बनेगा कुछ ना कुछ.
नहीं सर, वो सब गड़बड़ करके आएगा.
Okay. I am reminded of a situation in an aeroplane. वो किसी को कोई problem हुआ है, ophthalmologist they said any doctor है, उसने कहा ophthalmologist है या orthopedician है, तो गया वो कुछ नहीं कर पाया, तो we need a different kind of doctor.
Yes.
This won't do.
And secondly, sir, the most affected part is their studies and their thesis.
Okay.
And see, their protocols are the methodology or their protocol is sanctioned by the IC that their study population is where they are working. But when they are working in a DRP and if simultaneously they are doing their research work, because they have a very limited time to complete their.
That is lacking. I think Ram has
yes.
already highlighted that point.
Yes.
The thesis work suffers.
Yes.
But resident to push it.
Sir, why there some
Navneeta, resident is happy or not? About the thesis. Ram is a senior resident.
Go with the present DRP system. With DRP, the government or the NMC is
point.
taking some modification in the DRP, taking care so many points. And sir, there are certain hospitals which I got the news from my residents only that the civil surgeon or the CMOs are treating them that they are coming here just for 1 day, the first day and the last day. And they are demanding money also. It's a real fact, sir. It's a real fact just to get the attendance in the DRP for 30 days or for 3 months. A lot of things are going on, so we have to look at from different perspectives.
Yeah. ये मजा आ रहा है. There are 4 people lined up. ऐसे लग रहा है IAP की जनरल बॉडी मीटिंग चल रही है. प्रियंका.
Sir, I am.
Dr. Priyanka is head of the department at ESI Faridabad.
Sir, I will speak in favor of DRP, sir. I speak in favor of DRP. My points are that how many of us, sir, how many of us have developed the logbook for DRP as a faculty? Like when I'm sending my PGs to DRP, do I give them learning objectives? Like I work at ESIC Faridabad, we have BK Basha Khan Hospital just behind our hospital. Our PGs go there, so some of the PGs we are told that we have to go DEIC center, which is not available in many of the government or private medical colleges. So they have an opportunity to see how it runs. Also the SNCUs, like, and many of the faculty nowadays they are going into the super specialties. So they really get a feel of how SNCU, how DIC, how the actually community pediatric runs.
So you are in favor of the
also of the thesis, many taking part which they were not getting time in the department. So
thank you. Purushottam sir. Yes, ma'am. After Joseph ma'am. After Dr. Purushottam.
Sir, I am for DRP, sir. The reason being, sir, NMC has introduced this NRP for some reason. Probably before introducing any of the program, probably they would have done proper background homework. Okay. So if we introduce any new programs or any kind of these things, definitely we will be facing some of the challenges. What I personally feel is, so yeah, they have found so many lacunas there. As administrators, as a persons, probably we are supposed to identify where the problem is lying. Probably we are supposed to concentrate on filling those gaps. And he has mentioned with respect to stipend, with respect to female insecurities and so many things it can be solved at many platforms. So this
So
should
you
not be
need to
an
say,
hindrance
yeah,
for
there are
us.
challenges.
There are
but
challenges we are
we can
supposed to
find the ways to overcome these
overcome
challenges.
this and
But we definitely need to know their problems so that we can act on it.
Yeah, you are supposed to kind of take your problems to the immediate administrators or immediate things. You can please discuss with them. They come up with the solutions. Probably they can fill the gaps and can go ahead with this.
Thank you, sir. Thank you. Jyotsna, ma'am.
Sir, I would like
Bill, I think we have to finish the session. I am getting signals from the organization.
just 2 minutes.
Yes, ma'am.
For MP situation, what I have worked in, nowadays, initially, ठीक है सब गायब हो जाते थे, but now they have a Darpan app. For that, they have to be there to do the things. Number 2, many districts are there where SNC are run with either one doctor or a part-time doctor. There, this presence of our postgraduate who has done 1 year residency in medical college is of crucial importance. And if they are posted there, it is really helping the newborn and the sick children where there are PICU and SNCU but not round-the-clock doctors. So their presence is very important. Number 3, I had been PI, state PI for the program which HIMS Dehradun under Dr. Berari, they started training of in 4 states, the training of all the postgraduates before they go on standard workflow of ICMR developed, and there we called even the district pediatrician who will be looking after these students. So they are in accordance with the system or the treatment protocols. So if we really take care of all these things, and there you can write thesis, write review of literature, so many things you can do. Data collection can be done and then you can do it sincerely. Investigation which are available in districts, drugs which are available in districts, many times they are not there in the medical college. So, and especially for private medical colleges where the workload is very limited, there the students are very keen to go to DRP. There they see the patients, make videos. I have seen this and after joining an medical college. There the students, they go, make the videos and share with their friends that these are the type of things.
This is new to me entirely.
Yes.
So this is fantastic. Because कुछ ऐसे भी हैं places जहाँ उनको लगता है कि वो medical college से ज़्यादा सीख गए in the community. Thank you, ma'am. Thank you so much. Yeah, that's it.
Thank you. I am in favor of DRP because a person has to get exposure all the time. He only not want to become a specialist, but he is a general person so that throughout of his life he can do each and everything wherever is possible, whatever is required, so he can perform it. So he is a jack of all. Although the master of that is, but he is jack of all. He can do everything. So I am in favor of DRP.
Thank you, sir. Ma'am.
Sir, I am against the DRP because in medical colleges where the number of PG seats are limited, when we are sending our residents to the district hospitals or at other district, it is hampering the work situation of the...
Sir, I'll stop after Dr. Ravi. Please, we have to close the session.
So it
मुझे यहाँ से signal आ रहे हैं बार-बार.
It is affecting the functioning of the tertiary care center also because the number of hands has limited. Plus they are posted, they are not posted exactly in pediatric department. They are doing the general duties, they are becoming the medical officer, they are becoming the CMO duties, night duties they were doing, and they do not have any exposure of pediatric. So it may be good for the private medical colleges, but it is not good for the newer medical colleges.
Thank you, ma'am. Ravi, Dr. Ravi. चलो इसके बाद कोई please
Thank you, sir, for giving the opportunity. At the outset, I congratulate Dr. Namit and Ram for this eye-opener discussion. Wonderful. Dr. Ram, I want to ask you rather. You raised the sort of voice that some unethical practices residents are forced. I think as the Dr. Ramchandran said, that elephant in the room and somebody has to acknowledge it. Some of the residents reported that when they go to DRP, they have to pay whether they come or not at certain places for the attendance. I think this is one of the major reasons I am against the present DRP practice. Thank you.
Dr. Mahesh.
Thank you, sir. Thank you for the opportunity. I think
why I am here is there is already most of the institutes and most of the states are immediate service bound after completing your post graduation. So you are already going to the district hospital for 1 year or 2 years or depending on different state norms. So you are already going there. I don't think there is any additional advantage that they are getting in going in between the 3-year duration for 3 months and creating the problem in the department also. At the same time, probably I think there is no need.
Harish sir, final remark by Dr. Harish.
Sir, very quickly, there is a policy issue in that. PGs are supposed to work under supervision of an expert or a faculty. In DRP, many a time they are posted in a place where specialists are not there. My daughter is a psychiatrist, she was posted under dentist. So such things should not happen. And moreover, AIMS Delhi has a very long program of residency in
The last, yes sir.
See, the name is the district residency program. And see, nowadays almost all districts are having the students because of their security concerns. They have been posted in district hospital. So, as such, I am not finding any major difference over there. And even after going, what is happening? Few of the hospitals they are utilizing them as a replacement because they are also MBBS doctors are having the round-the-clock duties. So these people, the residents are just acting as a replacement for them. And as highlighted by most of them, there is no standardized structure how to teach them in district residency program.
Thank you. So finally, I just wanted. So there were the mixed feelings in the residents also. You can read this paper. I won't go into the details because of the shortage of time. It's been a wonderful session. Thank you, Ram. Thank you, Namita. Thank you all for your cooperation and participation. Thank you.